Thank you, Shailendra, for a nice and elaborate introduction. This is quite a ideal setup. So monsoon has already set in, and we are experiencing the first or second drizzle outside. And this evening provides us opportunity to share some of the knowledge with our colleagues. So thank you, all those my senior and colleagues who have joined in for today's CME. And I also take this opportunity to thank Salindra and Naveen, both from Pfizer, to organize this CME and giving me an opportunity to speak on a very, very important topic, which is quite very important for a physician because we come across the risk factors for stroke in our daily practice. And atrial fibrillation, as we all know, that atrial fibrillation is the most important, rather very notable risk factor so far as occurrence of a stroke is concerned, and mostly in elderly individual. So we shall be devoting today's evening talk on this atrial fibrillation, stroke, and how this novel molecule, that is NOACs, that is non-vitamin K antagonists, anticoagulants, they are helping to improve the situations and giving rather relief to the patients suffering from a stroke and recurrent strokes. So we shall be devoting time on examining the various aspects of the several groups of NOACs, and especially we shall focus our attention on the newer molecule ipexaban, which has so far stood the test of time and providing a spectrum which is quite suited for use in case of atrial fibrillation for the prevention of a stroke and re-stroke. So we all know that atrial fibrillation is an established risk factor for a stroke, and quite a good number of, rather a huge number of patients are suffering from stroke. Maybe it may be associated with several other cardiac and non-cardiac comorbid conditions, but most of the time, especially in elderly, it is the lone atrial fibrillation. Which is not usually associated with other any cardiac and non-cardiac conditions. So we are only concerned with knowing the details of atrial fibrillation and association of a stroke, and how the introduction of NOACs have improved the spectrum of giving relief to these patients. So we all know that atrial fibrillation is the major risk factor for the first and recurrent stroke, and 20 to 30% of all strokes are associated with atrial fibrillation. And atrial fibrillation increases the risk of a stroke by 5-fold. So this is quite a staggering statistics to know. And the risk of a stroke among patients with atrial fibrillation ranges between 1% and 20% per year. And the incidence of a stroke associated with atrial fibrillation increases with age, ranging from 6.7% in people with aged 50 to 59 years to 36.2% in those aged 80 to 89 years. So as the individual ages, so is the incidence of atrial fibrillation and its association with the stroke. So far we have been using oral anticoagulant drugs, and vitamin K antagonist oral anticoagulant group of drugs, especially warfarin, for the prevention of a stroke in our patients of atrial fibrillation. And we all know that reduction in long-term stroke risk, for that this oral anticoagulant is recommended for long-term stroke reduction in atrial fibrillation patients. And it also brings about a reduction in the post-stroke mortality, and with the use of this oral anticoagulant, we also achieve a reduction in the number of cases of ischemic stroke. But with the introduction of the newer, rather non-vitamin K oral anticoagulants, this has improved the situation, and newer anticoagulants reduce the risk of intracranial hemorrhage more than vitamin K antagonists. And this NOACs have also been seen to confer lower risk of major bleeding than vitamin K antagonists. Oral anticoagulation with warfarin has been the pharmacologic standard for stroke reduction in patients with atrial fibrillation up till now, and is still it is widely used, and especially in certain situations in which even the NOACs is not proving up to the mark, then the use of warfarin is still justified in those conditions. We shall be discussing those conditions later in our discussions. So let us focus on the secondary stroke prevention and role of NOACs. We know that there are several studies conducted, and one of this important study published in Lancet Neurology by J. Easton et al. They compared this NOAC apixaban versus warfarin in patients with atrial fibrillation and with previous history of a stroke or transient ischemic stroke. The study goes by the name of Aristotle, and this is a subgroup analysis. And the conclusion derived from this study that rate of a stroke of systemic embolism in apixaban versus warfarin group was 2.46% versus 3.2 per 100 patient per year follow-up, and with a hazard ratio of 0.6 and 95% clearance in this confidence interval, and 0.56 to 1.03. So this is an analysis from a subgroup analysis of Aristotle study, and this study also showed that there was absolute reduction in the rate of stroke and systemic embolism with apixaban vis-a-vis warfarin. It was 0.77% 100 patient year of follow-up. And this consistent outcome was observed with apixaban versus warfarin therapy in patients with atrial fibrillation with and without previous stroke or transient ischemic stroke. Apixaban demonstrated better efficacy versus warfarin in patients with atrial fibrillation and previous stroke or transient ischemic stroke who are at higher risk of a stroke, bleeding, and death. So this was important outcome from this study. And the NOACs versus warfarin were studied for this stroke prevention in atrial fibrillation, that is SPF, and this RELY and ROCKET AF study was undertaken, and we are discussing these two studies here. And RELY study was conducted with dabigatran versus warfarin, and it was shown that the relative risk of a stroke of systemic embolism was lower with dabigatran 110 and 150 milligram than that of warfarin. On the left side panel you can see that the dabigatran in the dose of 110 milligram and 150 milligram giving incidence of this 2.32 and 2.0% as against this 2.74% with warfarin. So this was an important study, RELY study, and this was a randomized evaluation of long-term anticoagulation therapy. And another study with this another NOAC molecule rivaroxaban versus warfarin. This goes by the name of ROCKET AF, and this was a rivaroxaban once daily oral direct factor 10A inhibition compared with vitamin K antagonism for prevention of stroke and embolism. And this trial was conducted in the atrial fibrillation patients, and you can see that rivaroxaban was found non-inferior to warfarin for the prevention of a stroke or systemic embolism in patients with atrial fibrillation. So these are the outcomes from famous RELY and ROCKET AF study. Now, you are seeing on your screen the meta-analysis of NOACs versus warfarin and in stroke or this systemic embolism, and all these studies were undertaken in the analysis, And this NOAC versus warfarin in patients with prior transient ischemic attack or ischemic stroke were studied. And this has the reference of Aristotle study in gas, AF TIMI 48 study, Rely study, and Rocket AF study. And you can see the sample size. This is a very significant sample size. And it was found that there was 14% risk reduction for recurrent stroke and systemic embolism. And in this study, this also emerged out that there were 49% risk reduction for hemorrhagic stroke with the use of NOACs. And the further extrapolation from the study, the mortality from any cause, there was 10% risk reduction for mortality. So quite significant finding so far as use of NOACs were considered. And this meta-analysis also showed regarding this major bleeding that there were 11% risk reduction for major bleeding as compared to warfarin, that is conventional oral anticoagulant. And this we are also seeing this data from network meta-analysis, which was published in Neural Disorders by Katsansos et al. In 2016, and this compared this dabigatran apixaban versus the older drugs. Apixaban has a comparatively better benefit to risk ratio profile among NOACs, and apixaban is ranked as the most likely treatment option to reduce stroke and systemic embolism as well as major bleeding. The most likely treatment option to reduce ischemic stroke, and the second most likely treatment option to reduce hemorrhagic stroke. So apixaban has proved the test in all these studies, and this has proved to be the most likely option to reduce ischemic stroke and the second most likely treatment option to reduce hemorrhagic stroke. This is a sub-analysis from Aristofan study, which compares NOACs versus warfarin in patients with prior stroke or systemic embolism. And of course, there are no adequate and well-controlled head-to-head clinical trials comparing efficacy and safety of apixaban to any of the other NOACs. Hence, the analysis presented does not imply a comparison of efficacy, safety, or product interchangeability. But in this study, apixaban was shown to confer favorable effect versus warfarin as compared to other NOACs versus warfarin in terms of stroke or systemic embolization and measure bleeding events in patients with prior stroke or systemic embolism. So actually, there were no head-to-head study comparing the various NOACs, but this study gave an idea that this apixaban confers favorable effect versus other this oral anticoagulant drugs. Let us now see what are the recommendations of the European Society of Cardiology on secondary prevention, stroke prevention in atrial fibrillation. The first three are the class 1 and level 1, class 1 and level A recommendations. So they are strongly favored recommendations with a firm ground, with a evidence backing of the various trial. And the recommendations for the use of this new NOACs are that for stroke prevention in atrial fibrillation patients who are eligible for oral anticoagulation, NOACs are recommended in preference to vitamin K antagonists, excluding, of course, patients with mechanical heart valves or moderate to severe mitral stenosis. We all know that these are two conditions in which the vitamin K antagonists are still preferred, and they are exclusively used in these conditions. Of course, so the non-valvular indications of non-valvular atrial fibrillation is no longer now strictly followed, as this new group of molecules, that is NOACs, are also showing their efficacy and safety in other valvular affections except this mild to moderate to severe mitral stenosis and the mechanical prosthetic valve of the heart. So in these two conditions, vitamin K antagonists are used. Other than these, in other valvular conditions, also NOACs can be used. It has proved its safety and efficacy. For stroke risk assessment, a risk factor based approach is recommended. We all are quite familiar with this CHA2, DS2 vascular score, CHAD-VAS score. This is a clinical scoring system, and it is used to identify patients at risk of having this stroke. So the patients with low risk are those patients which have a CHAD score of 0 in men or 1 in women. And these these individuals, that is a score of 0 in men and a score of 1 in women, they should not be offered antithrombotic therapy. So this is clear-cut indication and class 1 level A indication. Oral anticoagulant is recommended for stroke prevention in atrial fibrillation with CHA2, DS2 vascular score more than 2 in men or 3 or more in women. So this is strongly oral anticoagulants are strongly recommended in individuals having CHAD score of 2 or more in men and 3 or more in women. This is also a class 1 and level A indication recommendations. So this is a clear-cut indication. Oral anticoagulants should be considered for stroke prevention in atrial fibrillation. Should be considered. This is not a strong recommendation, but should be considered for strong prevention in atrial fibrillation patients with a CHA2, DS2 vascular score of 1 in men and 2 in women. So above 2 in men and 3 in women is unambiguous. There is clear-cut indication, but it should be considered in a score of 1 in men and 2 in women. And treatment should be individualized based on net clinical benefit and consideration of the patient's values and preferences. This is class 2A and level B indication. And for bleeding risk assessment, we have a Hasbled scoring system. We all are quite familiar. And a formal structure, this is a formal structured risk score based bleeding risk assessment is recommended to help identify non-modifiable and address modifiable bleeding risk factors in all atrial fibrillation patients and to identify patients potentially at high risk of bleeding who should be scheduled for early and more frequent clinical review and follow-up. This is also a class 1 and level B indication. So we all are this CHAD-VAS scoring and Hasbled scoring. We must employ these risk calculators, and we should rather calculate the risk of our patients and employ the use of this CHAD-VAS. We all know that all these factors are taken into the consideration for scoring: congestive heart failure, hypertension, age equal to or more than 75 years, then diabetes mellitus, stroke, vascular disease, any presence of any vascular disease, or age more than 65 and less than 74, and especially female sex. And in Hasbled studies, the scoring is taken based on these points, that is presence of hypertension, any abnormal liver or renal function, a stroke or bleeding history, or predisposition to any bleeding complications. Then labile INR, in which INR is not stable, and we are getting a labile INR in our patient. They should also be taken as a risk factors, and elderly more than 65 years, and of course those individuals who are indulging in the use of some other drugs and alcohol concomitantly, they should be also taken for this risk score calculation in Hasbled system scoring. So this is regarding the CHAD score and Hasbled score, and how utilizing these two scoring system we calculate the risk of an individual of getting a stroke, and accordingly we institute the treatment with NOACs. Regarding initiation or resumption of anticoagulation depending on severity of a stroke. So this the picture that you are seeing on your screen gives a very simplified view, and this was presented by Diner et al. In Journal of Stroke in 2016. And this is based on the NHSS scoring system. And we all know this is a National Institute of Health Stroke Scale Severity Score. and this is based on the several parameters, several clinical parameters of a patient affected with a stroke, and we calculate the scores, and the mild is taken as the NIHS score less than 8, moderate is a score between 8 and 16, and severe is taken as more than 16. So this is a stroke severity scoring system, and when to initiate or when to resume anticoagulation in those patients who already was using anticoagulation and then he has a stroke. So this table answers that question, that when to initiate or when to resume NOACs, depending on it depends on the infarct size. And this is a Diner's rule, 1, 3, 6, and 12-day rule. And at the onset, if the patient is having transient ischemic attack and atrial fibrillation, we can start anticoagulation right from the first day. And if our patient is having mild stroke, that is mild, we have already discussed NIHSS score, that is less than 8. In those individuals, anticoagulation can be started 3 days after symptom onset, or after the imaging has excluded an intracranial hemorrhage. So this is quite very, very important, that in a case of a stroke, we must try to exclude hemorrhagic stroke within the first 3 days. Then only we can start anticoagulation after the 3rd day. In individuals having moderate risk for this stroke, moderate severity, then this anticoagulation should be started after 5 to 7 days from the stroke onset. And in severe stroke patients, 12 to 14 days time period is required to initiate or resume the anticoagulation. So this gives a very, very simplified overview regarding the initiation and resumption of anticoagulation depending on the severity of a stroke. And this also has the backing of the recommendations, and you can see the recommendations for secondary stroke prevention in atrial fibrillation patients after acute ischemic stroke. In AF patients with an ischemic stroke or TIA, long-term secondary prevention of a stroke using oral anticoagulant is recommended if there is no strict contraindication to oral anticoagulant use, with a preference to NOACs, that is this non-vitamin K oral anticoagulants over vitamin K anticoagulants, warfarin. In NOAC eligible patients, of course, NOAC eligibility is there, and we have seen which patients are eligible for the NOACs and which are not eligible. We have discussed that the moderate and severe mitral stenosis and use of prosthetic valve, they are not eligible for the use of NOACs. In atrial fibrillation patients presenting with acute ischemic stroke, very early anticoagulation, that is less than 48 hours, using unfractionated heparin, low molecular weight heparin, or vitamin K antagonist is not recommended. We have already discussed it in our previous slide, that only after ruling out the presence of hemorrhagic stroke, then only we can start it after the lapse of 3 days. So within a period of 48 hours, we should not jump with the use of this unfractionated heparin, low molecular weight heparin, or vitamin K antagonist. Of course, we can use this NOACs in these conditions. We shall be discussing and rather seeing in our later slides. Recommendations for stroke prevention in atrial fibrillation patients after intracranial hemorrhage. If our patient has suffered a bleeding stroke, that is hemorrhagic stroke, in those conditions, atrial fibrillation patients are at high risk of this ischemic stroke, and in the reinitiation of oral anticoagulant. Even the patient was earlier using oral anticoagulants, and the patient has developed this hemorrhagic stroke, then it should be reinitiation, because the statistics are giving the result in favor of using of this oral anticoagulant drugs, and but the preference should be given to NOACs over vitamin K antagonists. and of course in NOAC eligible patients. And this should be considered in consultation with a neurologist or a stroke specialist in a case of a trauma-related intracranial hemorrhage or acute spontaneous intracranial hemorrhage, which includes, of course, subdural, subarachnoid, or intracerebral hemorrhage, after careful consideration of risk and benefits. So this is class 2A and level C recommendations. Now let us focus our attention with this issue of intracranial hemorrhage and microbleeding and the use of oral anticoagulants. And resuming this resumption of this oral anticoagulants after intracranial hemorrhage, is it beneficial? So this is a question that always arises in our minds while treating a patient of intracranial hemorrhage. So are we justified, or are we favoring our patients, or rather we expect a better outcome with the use of oral anticoagulants in a case of intracranial hemorrhage? The several studies were undertaken, and this is the report from this study published by J. Kuram Tasu published in JAMA in 2015. And this showed that the benefit of oral anticoagulant for the prevention of ischemic stroke is higher than the bleeding risk. So quite unequivocal statement. So benefit of prevention of ischemic stroke is higher than the bleeding risk in those patients who have already had a hemorrhagic stroke, and again we are using this oral anticoagulants. So this is a clear-cut indication. So initiation or resumption of oral anticoagulant after intracranial hemorrhage, this is class 2A and level C recommendations. That in atrial fibrillation patients at a high risk of ischemic stroke, reinitiation of oral anticoagulant with preference for NOACs over vitamin K antagonists in NOAC eligible patients should be considered in consultation with a neurologist or stroke specialist after trauma-related intracranial hemorrhage or acute spontaneous intracranial hemorrhage, which includes subdural, subarachnoid, intracerebral hemorrhage, after careful consideration of risk and benefit. And this again a study by P. Nelson et al. Published in Stroke 2019, comparing the use of NOACs versus warfarin in atrial fibrillation patient with intracranial hemorrhage. The follow-up period, this study was rather followed at the end of 1 year and at the end of 3 years, and this parameters, that is ischemic stroke and recurrent intracerebral hemorrhage, were examined, and it was seen that based on inverse probability treatment weighted cumulative incidence curves, warfarin therapy demonstrated a higher risk of ischemic stroke and intracerebral hemorrhage incidence versus this non-vitamin K oral antagonist therapy. So anticoagulant therapy. So this NOACs definitely scores over this conventional warfarin therapy in those conditions. And NOACs were associated with a non-significant lower risk of ischemic stroke. Of course, it was a non-significant risk, but it was definitely there that it was associated with a lower risk of ischemic stroke and recurrent intracranial hemorrhage as compared to warfarin. And regarding this microbleeds on MRI, which was seen in a case of stroke, and this is a report from a pooled analysis of 38 studies comprising 20,322 patients, and it was seen that the rate of intracranial hemorrhage increased with increasing cerebral microbleed burden. So if the patient is having microbleed repeatedly, then intracranial hemorrhage is likely to happen in those patients. And in patients with recent ischemic stroke or TIA, this cerebral microbleeds are associated with high subsequent intracranial hemorrhage. And the further extrapolation of this study, it was seen that there was no increase in the cerebral microbleed with NOACs. So cerebral microbleeds did not develop in the 23 patients with NOACs for 1 year. And a cumulative, this multivariate regression analysis, warfarin was independently related to the new development of cerebral microbleeds. So warfarin was associated with a little more incidence of microbleeds as compared to NOACs. And it was concluded in these studies that NOACs do not increase cerebral microbleeds in atrial fibrillation patients longitudinally in 1 year time frame. So now let us see the actual scenarios with the example of some cases regarding this non-vitamin K antagonist oral anticoagulants in the management of stroke in patients with atrial fibrillation. And we shall be taking the example of a illustrative example of this patient. And it was a case of elderly individual, 77-year-old retired army officer, and he presented with persistent headache, unresponsive to analgesics, and the patient, the main complaints were that the patient staggered against the wall and was unable to stand unsupported due to weakness in his legs. 1 week prior, he had a period when he was unable to speak or understand words. Both the sessions lasted for around 15 to 20 minutes without any lapses of consciousness. His headache was increasing in intensity during the attacks. And regarding the medical history of this patient, the patient had a long-standing type 2 diabetes and persistent non-valvular atrial fibrillation. And his CHAD score, we have already discussed regarding this CHAD. CHAD score was 4 because he has diabetes, which gives a 2 point of score, and age equal to or more than 75 years, again 2 points. So 2 and 2, 4. So CHAD score was 4. And regarding this medication history, he was already on warfarin, that is vitamin K oral anticoagulant with a recent INR of 3. And metformin, he was using metformin 500 milligram twice daily for glycemic control. Initial evaluations showed that he was not having dizziness, no syncope, no motor weakness except for the reported incident that occurred 1 week back. And blood pressure was 140 by 85 millimeter of mercury. Heart rate was 92 beats per minute at rest, irregular pattern as he was having a atrial fibrillation. Detailed investigations, brain CT and CT angiogram, they both were normal. Hematological and biochemical profiles were also normal. And diffusion weighted MRI, a small lesion in the right hemisphere, it came out. And this diagnosis of transient ischemic attack was made, and he was started with low molecular weight heparin for a week, and after that his oral anticoagulant therapy was resumed. That is, he was taking earlier warfarin, and that warfarin was resumed after giving a 1 week treatment with low molecular weight heparin. Later on, warfarin was replaced with apixaban 5 milligram BID. And in follow-up, it was seen that his headaches subsided after 1 week of oral anticoagulant therapy. No further attack presented during hospitalization, and diffusion weighted MRI after 1, 3, and 12 months, there was no trace of thrombus. So switching over to warfarin from apixaban, we all know that warfarin therapy increases the risk of ischemic stroke. We have already seen in the different study examination, and by 71% during the first 30 days of initiation of warfarin therapy in patients with atrial fibrillation, and the risk remains highest during the first week. And considering his age along with better safety profile of apixaban over warfarin in patients with TIA, his anticoagulants therapy was changed to apixaban. And with the changing of this therapy, his headache subsided after 1 week of OSC therapy, and there was no further attacks during hospitalization. And this diffusion weighted MRI done after 1, 3, and 12 months, there were no trace of thrombus. So definitely apixaban therapy seems to be effective in preventing a stroke in patients with atrial fibrillation during a transient ischemic attack. Let us focus now on a second case of this recurrent TIA. A patient, 58-year-old banker, was presented with diffuse headache and intermittent dysgraphia. That is, we all know that this is disability in writing. He reported of mild visual disturbance lasting for 1 to 2 minutes and had recurrence of the same thrice since morning. He had mild left arm weakness and slurred speech. The patient experienced a short-lived episode of receptive dysphagia in the prior week. The patient was presented to hospital with symptomatic atrial fibrillation twice in the last 4 months, and successful electrical cardioversion to sinus rhythm was performed. Medical history: he had diabetes 10 years, and he was also having hyperlipidemia since last 4 years, and he was diagnosed with atrial fibrillation 2 years back, and his CHATS score was 2. Regarding the medical history, he was taking warfarin with a target INR 2 to 3, metformin using for glycemic control 500 mg twice daily, along with atorvastatin 40 mg once daily for dyslipidemia. And this, owing to unstable INR, his anticoagulation therapy was switched from warfarin to rivaroxaban, and it was used in the 15 mg once daily dose for 1 year. 1 year back, he was put on rivaroxaban, 15 mg OD. However, even with the use of this NOAC, he was presented with a couple of transient neurological symptom episodes, even while on rivaroxaban. So the introduction of this NOAC, that is rivaroxaban, did not also ameliorate his condition, and he presented with few neurological symptoms. And his initial evaluation showed that he was not having dizziness. He was oriented. His blood pressure was 130/95 millimeter of mercury. His heart rate was 87 beats per minute at rest with regular rhythm. And detailed irregular rhythm. Detailed investigation showed that he is having atrial fibrillation on ECG, and brain CT, CT angiogram, brain MRI, and they were all showing the evidence of acute and recent infarct. Hematological and biochemical profile were normal. So a diagnosis of recurrent transient ischemic attack, even while on NOAC, that is rivaroxaban, was made. And management was that he was asked to continue his regular medication except rivaroxaban. Rivaroxaban was changed to apixaban 5 mg twice a day. And during follow-up, it was seen that his headache has subsided 3 days after switching to oral anticoagulant therapy, that is switching from rivaroxaban to apixaban. And he reported no further neurological events at his 12 months follow-up. So even after the 12 months, even after the lapse of 12 months, he didn't have any further neurological events. So apixaban is ranked as most likely treatment option to reduce stroke or systemic embolism as well as measure bleeding. And we have seen with the various results of the several trials, Aristotle trial, Aristophanes, and Relay trial, then this meta-analysis of several trials, then analysis from the resources available on the net, that all these NOACs are rather safe and effective so far as prevention of a stroke is concerned, especially in the case of atrial fibrillation patient. But of course, in certain subsets of our population, those having moderate to severe mitral stenosis and those having mechanical prosthetic valve, they are not suitable candidate for use of this NOAC. But NOACs are increasingly being used and are associated with lower bleeding incidence than warfarin. Several studies have shown this result, and NOACs like apixaban were associated with better efficacy and safety versus warfarin in patients with atrial fibrillation and previous stroke or TIA, and also in elderly patients. Apixaban confers favorable effects vis-a-vis warfarin as compared to other NOACs versus warfarin in terms of stroke or systemic embolism, and measure bleeding events in patients with prior stroke and systemic embolism. We have seen the example of our second patient in which even after the use of rivaroxaban, he continued to have this neurological events. And after this addition of this, rather substitution of apixaban bring about a change in his symptomatology. Network meta-analysis data demonstrated apixaban as the treatment with the probable best benefit to risk ratio profile among NOACs for secondary stroke prevention, and NOACs were associated with a non-significant lower risk of ischemic stroke and recurrent intracranial hemorrhage versus warfarin in patients with atrial fibrillation sustaining intracranial hemorrhage. So we have seen enough evidences for the use of new this non-vitamin K oral anticoagulant drug for the prevention of a stroke, especially in AF patients. And these drugs are licensed to prevent this stroke and systemic embolism. And this is also quite effective in the prevention of venous thromboembolism. And this use of this drug has recently increased due to its safety and convenience profile. We all know that dosing is not a hassle with the use of this drug. One dose is rather recommended for each and every individual, irrespective of their age or body weight or other comorbid conditions. And these drugs, that is NOACs, are associated with lesser bleeding complications and mortality in contrast to traditional oral anticoagulant drugs. This class of drugs have already been in the market since 2010, when the first molecule of this class, that is dabigatran, was approved by the Food and Drug Administration. And we all know this is dabigatran is a direct thrombin inhibitor, and it inhibits the production of thrombin, which prevents the conversion of fibrin into fibrin, and thereby it exerts its anticoagulant effect. And this other NOACs, that is rivaroxaban, apixaban, and edoxaban. Edoxaban is not used in India up till now, but rivaroxaban and apixaban are being used in our country also, and they are this factor 10A antagonist, and by this mechanism they bring about anticoagulation. And these drugs have proved to be a very, very useful tool in the management of a stroke, especially in the atrial fibrillation patients. So thank you very much for giving me a patient hearing. How frequently is INR required in monitoring of AF patients? The question didn't say that which with the use of either VKA or NOACs. If I take this that with the use of NOACs, he wants to know it how frequently we should use. In new oral anticoagulants, this non-vitamin K oral anticoagulant use, frequent monitoring of these parameters, that is prothrombin time and INR, etc., is not required, because the therapeutic window is quite large, and the patient is not seen to have any complications, even with the prolonged unmonitored use of this NOACs. So in these cases, we should not be rather worry regarding frequent monitoring of this bleeding parameters. But of course, we should be rather watchful in patients, in those patients who are having renally compromised patients, because this rivaroxaban, dabigatran, and this other molecules, they are excreted mainly through the renal routes, except, of course, apixaban. Apixaban has lately, in a small study, has shown to be rather safe, comparatively safe in the even in renally compromised patients, and in a subset of patients on hemodialysis, this has also shown to be effective and rather safe. So, bearing this apixaban, other NOACs should be used restricted in a restricted way, and this frequent monitoring, at least 6 months in a 6 months or 1 year time, this renal profile must be done, and we should keep on monitoring the renal this creatinine clearance. And if the creatinine clearance is less than 25 ml per minute, of course, other this rivaroxaban and dabigatran, etc., they should not be used. This is not a judicious combination. Non-warfarin and actually we want to take the benefit from of the newer oral anticoagulant drugs. So we should not put our patient to further hazard with this warfarin. Of course, warfarin is still being used as they have low cost, and in certain cases they are rather useful. They are still exclusively used, as I have time and again I have said that in moderate to severe mitral stenosis and the patient having mechanical prosthetic valve, in these conditions they are safe. And in renally compromised patients also warfarin has got a role. So vitamin K antagonist warfarin is still there, and I think it will remain for a pretty longer period of time till we come out with some novel other NOACs. Thank you. Thank you, Sailendra, for speaking. Thank, thank you. Thank you, Sailendra and Naveen, for speaking so high about this present talk. I'm rather feeling very happy and elated. Thank you very much.